So welcome today to our session run as part of the multi-professional support unit at the Training Hub. And this is an update on asthma, and it's aimed at those who are already reviewing and managing asthma patients. So we've got it's Gemma that's doing the most of speaking today. I'm just helping out in part. So my name's Sarah Partridge. I'm a clinical pharmacist by background. I am a prescriber in asthma, and I do run a couple of clinics. But the main speaker today, I'm very delighted to have Gemma with me. So I'll let you introduce yourself.
No worries. Hi, I'm Gemma Bird. So I'm a practice nurse myself, and obviously I'm a practice nurse working for the Training Hub. I think quite a few of you that have signed up know me in some capacity anyway. I tried my hardest to get somebody else to do this session for us, and we reached out to lots of people, but I think due to winter pressures they couldn't. So you are lumbered with me today, and I've tried my best to look around and get anything relevant to update us all. So like Sarah said, I don't think there's enough to warrant the full hour, but hopefully there might be some snippets that will be useful to you. So
we've lost your voice, Gemma.
There you go. Sorry, it's because my mouse is misbehaving today, and it keeps doing what I don't want it to do. So if you lose me again, just let me know, and I'll unmute myself because I'm not doing it on purpose. So as a general rule, obviously just ask for normal kind of MS Teams respect and etiquette. So your cameras can be on or off. You are more than welcome to eat and drink in the background, because I appreciate a lot of you will be doing this on your break. You are welcome to unmute at the end when we're doing questions and answers, and you're welcome to put anything in the chat in the meantime. But just be warned, I can't see the chat at the moment. So if there's anything in the chat, I'll try and come to it at the end. Is it working? Yes. Has that gone forward for you now?
Yes.
Yeah, sorry, it's a bit slow my end. So aims of the session are basically just to go through any national or local changes that we're aware of. Sarah, as our clinical pharmacist, will be doing a bit of an update on the inhalers near the end. And I'm just going to go through some of the national guidance that's being updated and give you hopefully some useful bits of information. So I just started with this. I know I appreciate many of us have been doing asthma for a long time, and we probably know a lot of this anyway, but this is some current up-to-date figures that I wanted to make everybody aware of. So it's so important for us undertaking asthma reviews to ensure that we're keeping up to date. 3 people a day die of asthma attacks within the UK. Every 10 seconds someone has a life-threatening asthma attack, and at least 2 to 3% of primary care consultations are asthma reviews. And actually I did see another figure that showed that 25% of consultations within primary care actually around children and young people too, and a lot of that can be linked to respiratory, whether it's an asthma review or query, asthma related or respiratory related. So that's just another figure I didn't put down there, but I wanted you to be aware of. Locally, we've not been doing so well. So we've actually had 7 children unfortunately die of an asthma attack in the last 5 years in Nottingham alone. Other areas such as Lincolnshire, they've had none. So it's a small figure, but I think anybody agrees 1 child death is too many, especially when it's asthma. So the fact that we've had 7 in Nottinghamshire is quite appalling, really. And I'm really keen for us in primary care to make sure that we're on our top game, and we are reviewing children, we are diagnosing correctly, and we are managing them adequately. So asthma is responsible for 60,000 hospital admissions a year in the UK, and approximately 200,000 bed days each year are taken because of asthma attacks or poorly controlled asthma. So the most exciting news, and the thing I had to put here first, I don't know if anybody else feels my frustration, but obviously we have so many different guidelines that we have to go by. We've got NICE, which I know NHS always want us to follow NICE, but if you're like me, NICE is the last one I look at because it's always so outdated, not just for respiratory, but actually for anything. So the good news is BTS, SIGN and NICE are actually working and collaborating together on a guideline that will be set for us to use. And the first consultation will be going out for May and June, and we're hoping to have it, well, they're hoping to have it published for the 30th of October. So to me, that's exciting, because I now don't have to look at various different guidelines and then decide or try and guess what the best practice is. Hopefully this will be the most current, up-to-date and useful guidance to come out for a while. So in regards to NICE, obviously there hasn't really been much updated. The last guidance on there was from 2017, I think. So GINA, though, does have a lot more up-to-date information at the moment. So to save me attempting to do something as beautiful as this, because of, if anybody knows me, my IT is shocking. The good news is GINA had some amazing slides, so I was able to copy and paste and make myself look really good, but actually I haven't done any of this at all. So I think the most important thing for adults and adolescents is, I don't know if you can see my mouse cursor, but actually the first line now is they're recommending MART for everybody, basically. So instead of doing the ICS alone and then SABA as a reliever, actually they're saying let's go to the MART regime initially, because we've got proven evidence now. There's lots of research. MART is the one that is going to minimise exacerbations and is going to support control overall and minimise those hospital admissions. So basically we're taking a step back. So instead of going for the normal Clenil, although I appreciate, sorry Sarah, I know you're going to say something different now, which I still can't say, because it takes me a while to learn how to say these medication names. So instead of the normal, what would be Clenil or Qvar, for example, we're going to be going over to things like Foster, or is it Lefrebec or something like that is a new Foster?
Yeah, Lefrebec.
Lefrebec, there you go, you said it better.
There's Fobumix as well.
So those will be the first three, although obviously we need to follow the Nottinghamshire Formulary, but like I said, we'll go through that a bit later. So actually, when we are considering a trial of treatment, or when we are looking at, if we're reviewing them and if they're on Clenil, actually should we be considering changing them to a MART and educating them on the MART regime and why it's more important, and to ensure that they're using that instead of regular use of SABA alongside a Clenil as needed. Obviously they've got track 2, the alternative, which is kind of the same as what we've always been doing, but like I said, I just wanted to put that there, that ideally we need to be doing MART regime moving forward. So again, I've nicked this from GINA, so this is just the steps that you can take. So this is all available online. It's about a 35 page slide update. It's got a lot more useful stuff in, but I've tried to take the key elements from it. So this is obviously why GINA has changed their guidance. So track 1 or step 1 basically is this ICS formoterol preferred use. So obviously we've got all the steps there, which I won't read through because I know you're more than capable, and we will share these slides. And like I said, the GINA slides are available online as well. Yeah, I remember why I added this now. It was just exactly what I just said, that we've got proven records. Some of the research data and information is down at the bottom, but basically we know that if we are using a MART regime, we are going to significantly reduce severe exacerbations in some of our patients, which of course ultimately will lead to less deaths, less hospital admissions. So of course that's why I added it in. I just wanted to show that data that they'd shared with us. So this again was just the guidance. So I think hopefully all of us, because we are already doing asthma reviews, I'm going to use Foster. I'm so sorry, Sarah, you can smack my wrist after, but I'm so familiar with Foster. So I think a lot of us would have used Foster previously for the MART regime, and we would be using, well, it's a 100/6, isn't it, for the Foster. The 200 one isn't licensed for MART, so it'd be the 100/6 for Foster, although like I said, we have got some information on the inhalers later. But again, this is just providing that information of what to tell patients and how to do it. A lot of the time, I know it says steps 4 and 5, but actually for a lot of my patients that I recommend MART with, it's because the 2 doses alone of the Foster in the morning and the evening wasn't always quite enough. So I put them on the MART and I change it. So they do 8 doses within 24 hours, but I just change it on the little leaflet or booklet that I use from Chiesi. And I put, 4 doses as maintenance and then up to 4 additional doses during a day, just to make sure they do not go above the recommended doses. But actually, although it's steps 4 and 5 for a lot of my patients, when I was considering MARC beforehand, I'd already stepped them up to that 2 in the morning, 2 at night, and I didn't want them to take away from that, because actually they already needed that. But I didn't want to step up to that high dose if I didn't quite need it. If it was only on occasional days where they needed that top up, then the MARC regime was normally obviously a lot better, because we've not got that continuous high dose steroid if it's not always needed, but they had that flexibility. So although it's steps 4 and 5, it's just that reminder of, don't be scared to go to steps 4 and 5 as needed a bit soon if that's what your patient requires. Oh, so hang on a minute, I've got this up. So this is the Nottinghamshire Adult Asthma Treatment Summary. I just wanted to show you, I've got it up on here now. So this is what it currently looks like. So these are the ones that are being recommended for MARC regime. Obviously, they are trying to use more DPIs for adults, but it's just that reminder. And again, I'm sorry, pharmacist Sarah. Patient preference. There's no point trying to be green and looking at carbon footprint. If your patient is not going to be concordant with that medication, it's not going to be able to use a DPI correctly. So just use your common sense. You know, I appreciate we need to cost save in the NHS, and it's really, really important. And, you know, carbon footprint is massively important for the planet, but actually we will be causing a lot more issues and probably causing more of a carbon footprint if we keep changing around inhalers, because a patient doesn't get on with it, basically. So if we pick the correct inhaler, the correct management in the first place, we will be obviously supporting and managing that patient more effectively, and therefore hopefully minimising asthma attacks and hospital admissions. And we should not be impacting a massive carbon footprint anyway, because we won't be changing inhalers, overusing SABAs, or, you know, because they're relying on them because they couldn't get on with a DPI to begin with. So just to have that, you know, that common sense in the background, really. I know what we should be doing, but actually ultimately many of us nurses will go, but what's best for my patient? I know we've got new guidance, but actually what is my patient going to do, and what are they going to actually follow? So this, again, the link is in the slides, which we will send out to you, although I think most of you probably are aware of this and have got you know, got the links to this anyway. So let me just go back to the slide. From current slide.
And the good thing about that guidance is it's starting to move towards MART therapy.
Yeah, I think it looked like they'd updated theirs in November, which is great. And like I said, I think the inhaler part has all been correct. Well, it looks, obviously I'm not an expert. It looked correct to me, and it looks like the ones that most of us tend to be using and following as per sort of national guidance anyway. But like I said, the national guidance is definitely much more for MARC. So, but obviously it's got the correct inhalers on there anyway that we should be going for first line. But like I said, patient consideration, really. So just moving on, because in adults, truthfully, I couldn't find an awful lot more than that. Everything else seemed to be very similar to what we've been doing for the last couple of years. But like I said, there's stuff that I could have easily missed, or not aware of myself. So if anybody is aware of anything quite important, please feel free to raise it at the end or pop it in the chat, because like I said, I was trying my best to find you a respiratory specialist, but I couldn't get anybody available at the moment. So I've tried my best, but if anybody knows that I've missed anything, please put it in there, because the point of today is shared learning. So if there's anything I'm not aware of or haven't said, I'm more than happy for anybody else to share it within the group. So I just wanted to give you a little bit of an update as well on diagnosis and management in children with asthma. So in Nottinghamshire, I'll be completely honest and put my hands up that actually for years now, I was always advised, until they're a certain age or until we have undertaken a thing like a pheno or a spiro, I would code as suspected asthma, and I've done that for a long time. Actually, that is not best practice, as I found out recently, and Nottinghamshire are very keen for us, if we suspect asthma in any way, i.e. they've got you know, appropriate symptoms, a good family history, things like the eczema and hay fever, all those overlapping symptoms actually code as asthma straight away. We can always remove the asthma code in the future if it turns out not to be, but more than likely when we've been coding as suspected asthma, more than likely they are asthmatic, and they want to make sure that nobody is missed off of reviews or when we undertake certain audits. So please, if you have been coded as suspected asthma, please change it to asthma. And like I said, don't be afraid to do that, because if it turns out, if they are ever reviewed by somebody and they've decided it is not asthma, we can easily take that off. And of course, ensure we've got an adequate recall in place. Treat appropriately, don't be afraid to trial treatment. So again, with a lot of children, not so much with nurses, sometimes GPs, I'm sorry if there's any GPs on there, a lot of blue inhalers, a lot of salbutamol or salamol is given first line, see if that helps. And although there is a time and a place for them to just have salamol only, actually, if we think there is a risk of asthma, or we think there is a potential for asthma, then they need a steroid. We need to trial a treatment. We need to get that steroid in. So we want to start them off on an ICS and then obviously a SABA in the background. I've got some more slides off of GINA in a minute, which I'll go through for the kids one, but we've also got the child asthma algorithm for Nottingham, which if I just escape this, bear with me 1 second, is here. So again, the link will be in the slides so everybody can easily access it or even save it into their favorites. I love a favorite on my login for work, because there's just too much, especially as practice nurse. We've got to be jack of all trades. So save it to your favorites so you know you can easily access it. Or on Ardens, a lot of the time on the Ardens templates, if you use System 1. I'm not so sure about EMIS. I'm really sorry, I haven't used EMIS for about 7 or 8 years, but for System 1 there's normally a link that you can easily access anyway. So this is the current children's asthma treatment algorithm. So as you can see, DPIs, I think I've put this on another slide, but it's really, really important. DPIs are not appropriate for anybody under the age of 5. So if you've got somebody 5 years or younger, I would avoid a DPI, just because it's not really licensed, most of them for under 5s, and the inhaler technique is not going to be good enough. You need them to have an MDI really via an aero chamber. So I think most of us, even for the slightly older kids, I tend to again go for Clenil is my first go-to. And again, always ensure it's through an aero chamber. And another thing to remember with aero chambers, again, which I've been guilty of until recently. So Deborah Forster is a paediatric specialist nurse over at Queen's, and I didn't quite realise. I knew the you know, the mouthed aero chambers, the yellow ones with the little bears. They're only really for the use of up to 5-year-olds, but I've got a lot of kids older that I still prescribe for, simply because if they preferred to have that mask version, and I would rather them have that if that's encouraged them to use an aero chamber. But it's really, really, really important for us to try and encourage a proper aero chamber with a mouthpiece rather than the mask for anybody over the age of 5. So I'm sure Deborah would appreciate me just trying to remind everybody, because like I said, I've been completely guilty of that myself as well. So let's go back to this. So this is, again, this is the GINA updated slides for 2023 for children's management of asthma. And as you can see, obviously, there is no MARC regime really licensed for this sort of age. I know MARC regime is used in some of these, but that's normally from specialists. That's the paediatric consultants and asthma specialist nurses in the hospital. So in primary care, I wouldn't recommend anybody is really doing that unless they've been given that advice or say so from the paediatric team. So we want to be looking at ICSs and obviously stepping up. We obviously would be, oh, I've done it again, haven't I? Sorry. We would be adding in Montelukast probably slightly earlier with children than maybe we would consider for adults, but not to forget, it's not just inhalers. Things like Montelukast are really, really useful for a lot of our asthma patients, especially children, but obviously adults as well. So let me try and go forward again. So this is the one for 5 years and younger. So the thing that interests me was that step one of, they're saying insufficient evidence for daily controller. So I would say if anybody's, if somebody's got just a wheeze and have had a one-off or certain episodes, of course they might get that from respiratory viruses that come along. But actually, if you think there is a strong if they have a strong family history of asthma, if they have ongoing symptoms that could be asthma, if they're getting ongoing episodes of exacerbations like respiratory viruses, viral wheeze, things like that, then actually should we be considering a trial of treatment a little bit earlier? Again, there's no sort of one fits all. I think you have to kind of use your own common sense and your own clinical judgment, really. And if you're unsure, most of us work in a team where I'm sure there's somebody else doing asthma, or you can go for practitioners. You might have a GP that is a respiratory lead, or there might be another practice nurse who does respiratory. Always feel free to talk things through, and and make sure you have a nose regular follow-ups with patients, especially with children, if you're considering any treatment or if you're trialing anything. So please make sure that follow-ups are always taking place. I know most of us will be doing that anyway. Next slide. I think that's it. I'm really sorry. I know it's a whistle-stop tour from me, but I'll pass over to Sarah to talk more about the inhalers. And Sarah, just let me know when you want me to go to next slide, and then we can do sort of a Q&A and a general update session between us after.
That's okay. There's been some good things happening in the chat. So this is very short. So just a few things that you'll notice changing. The formulary choices have shifted a little bit. So instead of Clenil being first line for the steroid only inhalers, we're now using Soprobec first line. I put a picture up there because quite often we refer to them as brown inhalers. But actually, if you look at the range of strengths, they're not all brown. So just be careful when talking to patients about inhalers, what colours you use, because you've got a lot of different colours there. The other big thing is Foster, which has always been popular within the area, and the first line will be Lufrabec. And I am aware actually that the medicines optimization team are going to come in and do a mass switch of patients from Foster to Lufrabec, just so that you know it's coming up, because it's going to have a massive cost saving. So just to be aware that that's happening. Again, the inhalers look different. The risk of that switch is very low because it's a like for like swap. It's the same inhaler device, it's the same dose. But of course, patients are always confused whenever we change. So just to be aware that that's happening. And then finally, just awareness of DPIs. I totally agree with what Gemma said about the best inhaler is one that the patient can use and will give us best control of asthma. An inhaler not used is not green. But where all is equal, then dry inhalers at the moment are the most cost effective with the green agenda in mind. And the most cost effective one is the Fobumix Easy Haler. To answer your question in the chat, does Lufrabec come in a DPI? The answer is no. So it doesn't have the range like Foster does. So if we wanted the dry powder, then Fobumix is first line, then the next Haler and things. So yeah, the only main issue with the Fobumix is it's the only dry powder that I'm aware of that you've got to shake. And the error that patients make is they quite often occlude the vents on the top. So when checking their technique, I've always find just keep an eye on that, because it's not a lot of the dry powder inhalers are the most user friendly, but there's just a few little nuances with the easy inhalers that we need to make sure that we check on. Next slide, Gemma. And yeah, good comment, Milan. The brand swapping is good, but yeah, hopefully the MedSop team have liaised to check there's enough stock by going to the alternatives. But I think it is a swap that a lot of areas are doing. Just quickly highlighting, I've brought this up before, there's a lot of greener, the green agenda is very big. Then Yeah, there's a lot of resources on the NOTS APC website, so the link is there if you want to see it. There's also kind of a policy there, so yeah, just be aware that it's there. But I assume you're all aware of that already because it's come up many times. But yeah, support and information for patients is on the NOTS APC website. Do you want to go to the next slide, Gemma? And then other useful resources that we've come across. So I really like the My Lungs for My Life website. It's got a lot of lifestyle videos. So how do you deal with asthma and exercise and things like that. It also has MDI and turbo inhaler videos in multiple languages. Another really useful link. So there's a lot of queries actually in the chat about what to do if you're having an acute attack, if you're on MARC therapy. And the easiest way to explain that is by using the MARC action plan. There is a link in the chat, there is a link here. That again is also available in lots of different languages, which is really helpful. And Gemma's also added the link. Do you want to talk about that, Gemma?
Yeah, no worries. So, first thing, just to go back to lungs, My Lungs, My Life. If you look at a lot of the GINA updates and also a lot of the research that's happened in recent years, they've shown massive improvement in asthma control for those that are actually using digital resources such as that to reflect on their symptoms, to log when they're using their inhalers, and to go to for things like general information about their condition and inhaler techniques. So again, that digital kind of format of things is really worth pushing, especially in our younger generations, because there is now proven evidence that if they've got a digital app or anything to assist them with managing their condition, it will make a big improvement. The thing that I wanted to add on here as well is the Fit to Care from PCRS. It's really, really helpful for those undertaking respiratory reviews or anybody new to it, because it just kind of gives advice of what level of training that you should have been having to be undertaking certain reviews. In general practice in the past, not so much nowadays, in the past people were a bit more guilty of see one, do one, and people being let off to, because it's just a tick box. It's really, these long-term condition reviews are not just a tick box. It's really, really important that we have some level of understanding. And I'm the first one to put my hands up and go, I'm not a respiratory specialist like our community colleagues or anything like that, but I know enough to get me through, and I know when I don't know, and that's really important, that I know when I need to reach out to somebody else and get a bit more advice. So please have a look at the Fit to Care and just make sure that whatever you're undertaking, you have had the relevant training, or you feel capable of what you're doing. If you are struggling, reach out to colleagues and ask for a little bit more support training to get you to the level that they may expect you at, or to adjust what you are seeing to fit the level that you're currently trained to. The MARC action, again, on the action plans, if you use system one, if you've got certain Arden's template, we're lucky we do have Arden's template, but actually they normally have links to the MARC action plans or the normal action plan. So just make sure that patients have an action plan at each review. A lot of them, especially adults, might decline them, but for kids, I will always give them an up-to-date one and just say, bring it into school if you don't need it yourself. It's really, really important that somebody has access to that. So yeah, just make sure you print off the right action plan for whoever you're seeing.
Yeah, and shockingly, apparently nationally, 7 out of 10 asthma patients don't have action plans.
So some of it, to be fair, a lot of my adults do decline because I know what I'm doing. I was like, it's fair enough. If you don't want one, that's no problem. I'll just write it in there, or put asthma action plan reviewed if there's no changes. But kids, especially, really important for kids, I think, just to make sure they do have one. And actually, you'd be surprised for some of the adults that you do ask. Some of them do want it. But yeah, it's definitely harder I find it harder to get adults to take one personally. There's a couple of we put the QR codes to make this a bit easier on this one. So Education for Health have a severe asthma masterclass series. A lot of you might be aware of it either from certain online forums or whether you've done training of Education for Health, you may have had the email. but it looks like one of the pharmaceutical companies are funding 75% of a severe asthma masterclass series, which looks quite useful actually. So we just wanted to make you aware of that because that could be really helpful for some. And of course, at the training hub, there is still some CPD money for practice nurses. So you could even potentially put a request through to see if there's any funding to cover the rest of that for you. And also something that's really important is there's online asthma training courses, e-learning. And again, this is through Education for Health, but this has actually been funded and created by NHS England. And they have lots of various levels depending on how involved you are with children who have asthma. So there's sort of level 1, which is for things like teachers or youth workers and nursery workers. So you can recommend that obviously anybody you come across that are in those roles, that they do the e-learning for health training at level 1, just to make sure they've got a basic overview of asthma and how to support their children with asthma while they're in their care. But also there are some e-learning modules for us that are actually reviewing, and there's even more ones that are for specialist respiratory nurses as well. So it's worth having a look at that just to see if that is of any help to any of you. Any questions? What I'm going to do is if it's okay with you, Sarah, I'm going to come off this just so I can see the chat, and then we can sort of open the floor for general discussions, because I appreciate it was a whistle stop tour.
So I have been policing the chat. The first question that I couldn't answer and I needed you to help me with was, do we have evidence to suggest peak flows are not to be used in children? I wasn't aware of this. Yes. So where did that information come from?
So that has come from is it Dr. J.S. Batt, Dr. J.S. Batt and Deborah Forster. So those working in the paediatric asthma specialist team within the secondary care in Nottinghamshire have advised us that actually the BTS guidance, the updated one I was telling you about coming out next year, peak flows are not recommended in children. They're not saying completely no, because there are some places where peak flow diaries are useful in children, but that's normally more complex, and that's normally done by secondary care. They're saying in primary care we're not going to get any benefit from it, and actually we need to be undertaking Spiro, and if Spiro is not available, then a Pheno. But Spiro should be first line for most children, and they're recommending that us, especially because we're having to do the ARTP training, etc. now, and there is top-up modules you can do just to support you undertaking Spiros with children. So the new guidance that will be coming out in the first review of it in May and June will state peak flows are not for children. So I hope that helps.
So Kirsty Smith had a question about should they have a SABA for emergencies with MART? And my answer was, it depends on the patient. I risk assess that patient there. If they've not had any hospital admissions or any massive acute attacks, then I might say no, actually they don't have one at home. They can contact the practice if their condition was to suddenly decline. But if they've got brittle asthma, then I might say actually keep it and keep that for absolute emergencies, but generally follow the MART action plan. Would you say anything different, Gemma?
No, that's kind of what I do. If I cannot, because the problem is a lot of people over rely on the use of SABA, even if they don't think it. How many patients do you review where they say, oh, I take a blue one overnight? Why are you taking it? Are you symptomatic? Oh, I've always taken it overnight. They become reliant and it becomes a habit. And I want to take, it sounds awful, I kind of want to take that habit away because it's not benefiting them, and most of the time it's not needed. So I'd agree with Sarah. There's some, if they're at more risk of severe asthma attacks, if they've had a history of asthma attacks, then probably having a blue one on them is probably useful. But for majority of patients, they should be able to manage on MART alone. And as evidence has shown, it's not overuse of SABA, it's lack of use of ICS that causes poor control. And we really need to ensure they are getting the correct amount of ICS. And there's times where they need that topped up, hence why the MART regime is now being first line use for adults, basically.
Danielle was asking another question about the patient is on Clenil and we're switching them onto a DPI. Should we use Fobimix or the Easyhaler beclomethasone? Depends what stage of treatment you're following. If it's a like for like swatch, then you might go for the beclomethasone Easyhaler. But if you're stepping them up, you might consider MART, or just the standard ICS formoterol combination. The next question is for you, Gemma. What is your opinion on the value of peak flows at an adult review?
I have to be careful because obviously there is value for peak flows, and sometimes it's good to see whether there's that variability or not, and it does help. But for the general annual review, that helps with diagnosis. But for a general annual review, yes, I do them if they've brought their own peak flow, because with COVID and sort of one patient use and stuff, I don't tend to have one I keep. I try and make sure patients have got their own. But does it impact how I treat the patient? Truthfully, absolutely not. It makes no difference. Their peak flow might be very similar to what it's always been, but actually symptom wise, they're showing that they're not controlled as well as they should be. So I will change inhalers as per control. And sometimes their peak flow may be slightly less than it is, but their symptoms are generally well managed. So I'll be mindful of the fact their peak flow is down, and just say, obviously, they've got peak flow at home, keep an eye on it and make sure it stays steady, it's not dropping too much. But actually, I'm going by what the patient tells me. Are you showing any signs of exacerbation? Are you short of breath more often? Are you coughing more often? Are you chest tightness? Do you feel your asthma control is okay or not? And when I say okay, a lot of people will say, yeah, it's fine. Ask how often they're using the blue one, or ask how often they're using additional doses of their MART regime, because actually a lot of people go, my asthma's really well controlled. And then when I ask them questions, they're using a couple of doses of the blue inhaler each day, and I go, yeah, but my symptoms then go once I've used it. Brilliant, excellent. I want your symptoms to go when you're using it, but the fact that you're using it shows me your asthma's not controlled. So don't just go by when you go through that that ACT questionnaire. How do you think your asthma is controlled? Most people go, well controlled, completely controlled. Actually, ask them a few other questions, because sometimes we as clinicians might disagree with what that answer is. I just see something else in the chat, which actually I wanted to bring up with you, Sarah. So as a plea from practice nurses to the medicines management team, we had a lot of issues when you done this with the Salamol, and actually the results of the Salamol, I appreciate, is exactly the same medication, exactly the same dose, but actually the effectiveness of it, we had enough patients showing there was a massive problem. So when I'm putting them onto where I would normally put them onto Foster, obviously I'm using the new Lefurbeck inhaler, and I'm trying to change appropriately when I'm reviewing, but sometimes a blanket change can cause quite a lot of more added work for us as practice nurses. Is it something that medicines management could maybe discuss with the practices, and we could do more jointly? Because I appreciate for cost savings they need to do that, and that's part of their job. But if you're able to involve us practice nurses a bit more, because otherwise what happens is we kind of get the onslaught and then all of the issues after. Whereas maybe if we were managing them or doing it as per reviews, as was, done it in a sensible manner, we could make appropriate changes while reviewing patients at the same time. Just putting it out there.
I can pass that feedback on. I'm generally, yeah. I think they're gonna hopefully come in and do it on a practice by practice basis and provide enough resources and support information and things like that. There's a few questions in the chat back to peak flows. So Fareed has put, how do we check for variability?
So you want to have there is a calculation you can do, which I always still have to go online and do the calculation. There's like a little calculator you can do, or there is places with the calculation on, because I always forget it. But basically you're looking at the highest and lowest numbers, and morning and evening when they're taking it. So you want them to try and do at different times of the day as well. And then there is a calculation you can do to work out the percentage of variability. And obviously we're looking for sort of 20% or more of variability. I will see if I can find the one I use and pop it in the chat as well. Or if I can't find it in time for the end of this session, I will add it on to the slides before we send them out for you. Foster PRN is not on NOT's APC guide. It is on there, but they've put the Nexthaler on there, Abby, I think. But I use a lot of the MDIs because that's what patients prefer. So, but again, we should be using the Lefurbeck one now instead. I can't say that. It's an awful one to say, isn't it? Is it? I'm gonna have to create a nickname for it, I think. So,
but not the brown one, because they're not all brown. There was a question about what about peak flows and asthma review for children. I think you've kind of covered that.
Yeah, basically it looks like we definitely don't want to be using peak flows to support any sort of diagnosis, and there's not really a massive need to be doing a peak flow at each review. Like I said, the guidance that comes out in 2024 make that a lot clearer. But obviously that's the advice I've been given from the specialists in the local area, and they've been advised by colleagues that are actually sitting on the BTS panel who are writing it up at the moment. So it's not just been plucked out of thin air. So.
And Danielle's put, do you still advise them on their 80 and 50% peak flows based on their best? And if it drops
Yeah,
to 50% or less, to go to A&E or 999?
I think the reality is if I do so for the asthma action plans, especially for adults, I will, if I've got up-to-date relevant peak flows, then I will put the correct numbers into their asthma action plan to make sure they know what 80% drop would be in the peak flow number and 50% drop. I think again with the 50% drop, why have they had a 50% drop all of a sudden? If they've had a 50% drop, I would imagine they're going to be symptomatic, in which case we would be advising them appropriately. So if it's not acutely life-threatening or doesn't seem to be, then actually do they need to be coming to us within general practice having a review? Do we need to be changing inhalers appropriately? Or with a 50% drop, more than likely they may be more acutely unwell, in which case they give them the normal guidance that you would if you're struggling with breath. You use your inhaler, whether that's the MART regime or whether that's starting to use your blue inhaler. See whether your symptoms improve. You can always then check on your peak flow. But if your symptoms are not improving, then absolutely A&E or 999. I'd much rather them go and their symptoms resolve with adequate inhaler use, or for A&E to review and nebs and stuff like that, than them wait too long, because that's the issue in the UK. Is a lot of we underplay how vital asthma control is. And what happens is a lot of the asthma patients that die are not the ones that are severely or have severe asthma, because they're normally very aware of those symptoms and act on them appropriately. Actually, the ones that are dying are the ones that would normally be considered as mild asthma and have never had really an attack before. So they're not always given the correct guidance, or they don't always escalate things because they assume, oh, a couple of puffs my blue ones should go. And they've never really understood or know realize how bad their asthma could be, so they don't act on it quickly enough. So just giving them that guidance. So I think Zoe had put earlier on the chat about obviously 10 doses of the blue inhaler, and obviously you can keep going. But I always say to people, if you're getting to 5 or 6 doses of that blue inhaler, if you're still struggling, you call in 999 then. Don't wait till you get into 10 doses, because if that 10 doses isn't working, yes, you keep going, but something's seriously not right and you need medical attention. So don't wait till that later stage of it, act sooner. And like I said, I don't think there's a clinician, an ambulance man, an A&E nurse in the world that would be annoyed by somebody attending and actually things have settled by then, they could be reviewed and sent home, then not attending and then ending up with a worst case scenario. So yeah, I hope that answers your question. I realise I've gone off on a tangent. I always do. So
brilliant. Simran, to ask you a question, it could be a good opportunity to change their hospital discharge to Lifrabec. Might be worth to even just dropping them a text message saying you're doing it. It's always good to make the patient aware of any changes. And then Zoe has asked, and actually I've got this question, are you guys using in-check devices because of infection trolley issues? I've heard mixed things on this one.
I'm not using in-check device because I've not had one for a long time, although I did used to really like them and appreciate them because they were really, really helpful. But actually what patients should be doing is bringing their inhalers with them. We should be checking their inhaler technique at each review, and obviously going through that, or I even show them. I have my own devices that I use and showing them, so things like an MDI through an aero chamber and that noise it makes, and people are shocked at how lightly you need to be breathing it in, but obviously with DPIs they need to be breathing it in a bit more. So if you're doing adequate inhaler checks and showing the patient, and I also forward on videos and things like that, then actually in-check device, there's no right or wrong really. Infection control wise, I'm not the infection control specialist nurse around here. As long as it's being cleaned adequately in a different mouthpiece for each patient. I don't know, obviously through COVID it would have been a definite no, but now I assume we're back to normal. So if we're following the same guidance as we were before, probably no reason not to be using it. But like I said, you can easily review inhaler technique without using an in-check device, in my opinion.
It's just making sure they bring their inhalers, which is a bit hit or miss, I'm finding. And that's where you can get all your team involved in trying to encourage them on the importance of bringing their inhalers in. Any other questions? Feel free to unmute. We'd love to hear other voices. Or if you've got any other ideas or answers, then please put them in the chat as well, because actually some of you may know more than us.
I was also aware, I think the Symbicort is being licensed. I don't know whether it's already started or it will be. So from the ages of 12 onwards, Symbicort actually has a license, but I don't know when it will come down for us in primary care to be able to use that. But that's quite a useful thing to know. Again, that was from the PCRS 2-day conference back in September that was shared. So I'm not sure if people are aware of that or not, but I thought I'd put that out there. What dose do we offer a steroid card? If they're on a high dose steroid inhaler, they should have a steroid card. You can't order them, as far as I'm aware, you can't order them from anywhere anymore. So you have to download the ones online and print them out, which is annoying because I know my printer hasn't got any colour on it. So where it used to have a nice little red line and be a nice little alert card, it isn't. And obviously it's on thin NHS paper. So I don't think it has quite the same effect. But obviously, yes, you can print them online and just give the patient the correct guidance that if they do attend for any other medical treatment anywhere, they just update people that they're on a high dose inhaler. Check-in device, do we need to use this? Abby, no, technically you don't need to use it at all, but if you did want to use it, you can, the surgery can buy them in, and you're down the road from me, mate, so I can literally hop in the car, come and see you, and I'll show you how to use it. But basically it has a twist and you can decide what inhaler they're on, and they can practice their technique through it, and you can see whether they've got basically enough puff, especially for DPIs, to actually be able to inhale it in properly. Right Breathe is a fantastic site. Yeah, right. I have Right Breathe open all the time. Right Breathe, when I first started doing respiratory, was great because it had all my pathways and my step ups. So when I wasn't confident with my inhalers and what I should be doing, I used Right Breathe constantly. But even now, I still use Right Breathe because sometimes certain inhaler names change. You get a brand change, or somebody comes in with something weird and wacky that they've had in another surgery, and it's a great way for me to quickly look up what's actually in that inhaler if it's one I've not heard of before. And also, if somebody is struggling with a certain type of inhaler, sorry, I can have a look at alternatives that might have a slightly different steroid or LABA in it, and see if I can get an alternative that might be more use to them.
So Georgina raised concerns about documenting asthma straight away. Could affect future employment. I can get where you're coming from, but the problem is if we don't put that code in, then they get lost to follow up and don't get any recalls. I assume that's that, and we've got to look at removing that code.
Yeah, that's what I was going to say, because what you won't be doing is you won't be putting asthma resolved. So it should never show up that they've had asthma. They should be removing the code because they were never asthmatic. But like I said, the children, young people's respiratory kind of network in NOTS are really, really keen for us to be coding as asthma as soon as we think it is asthma and we're treating it as asthma. Like I said, we can always remove medications, we can always remove that code, so hopefully it should not affect them for any future RAF applications they're doing. So yeah, but just make sure you're not putting asthma resolved, because actually it was never asthma in the first place. So
I didn't realise I could not go into the RAF being an asthmatic, so there we are. Any other last questions? Otherwise, hopefully you found this session useful. Thank you so much, Gemma, for doing that. Do children need Spiro before you start them on a preventer inhaler?
No. So if you're like us, most of us would probably have a bit of a waiting list for Spiro. We don't have enough clinics. So absolutely not. If they've, like I said, it's the most important thing with respiratory, it's history taking. If they have a decent enough history to warrant probably a diagnosis of asthma, if they've got the atopy, if they've got the family history, if they've got the symptoms, trial a treatment, and then obviously add them to the Spiro waiting list and book them in, and just obviously make sure we're following the correct guidance for Spiro with certain inhalers being stopped so many hours before. But no, they do not need a Spiro before you start them on a preventer, because again, this is the biggest issue, and this is why they're keen for us to code as asthma, even if we're still got a little bit of doubt, is we take too long in treating appropriately with that ICS, and that ICS is so important. So if you're considering asthma, get them started on an ICS, do a trial of treatment, make sure there is appropriate follow-ups in place, and obviously add them to the Spiro. But no, do not I can't get my words out today, I never can. Don't prevent yourself from starting an ICS because I've not had a Spiro. Can we use smart PRN? Yes, you can. That's kind of the point of my, obviously they normally have a regular dose, one dose in the morning and evening, or like I said, some are even doing 2 morning and evening, and then they've got additional doses to use through the day. Even on that GINA guidance, they said even if the patient takes just 1 dose once a day on a regular and then uses it PRN, that's absolutely fine. But just so long as the patients are aware of the maximum dosages within 24 hours, because that's the key. I don't want them to say PRN and then they're taking 10, 12 doses in a day when actually they shouldn't be. So long as they're following the correct advice and the correct amount, so yeah, they would be taking it as and when.
Just to clarify, so MART is when you're taking it regularly, normally morning and evening, and when needed. So it's maintenance and reliever treatment. The use of ICS and formoterol just when needed. The only one licensed at the moment in the UK is Symbicort. I think there is a class licensing going through. So MART is all good, but that is normally regular and when needed. But GINA also states the use of ICS and formoterol just as needed, and at the moment the only one licensed in the UK is Symbicort. So just to be aware of that, a class license will be coming, and I suspect guidance will change.
So I was going to say, if I quickly share my screen again, that's what's changing on the GINA thing. So if you have a look there, steps 1 and 2.
National and local guidance haven't caught up with this yet. So just if you're making treatment decisions, just be aware of that. You've got to be confident and look at the evidence yourself if you're doing something that's not off national and local guidance, just so that you're aware. But that's a very important guidance there, GINA, and I suspect we will all go towards them.
You can see who's a professional and who's a bit more not quite just follows what I think should be happening. So like I said, NICE and the local guidance and things like that are always slightly behind, so I always tend to look at GINA. But yes, we do, for our registration and for everything else, we do need to be mindful. I'm sorry, I'm being a bit dodgy there, wasn't I? Like, this is what GINA is saying, and this is best practice.
You've looked at the evidence and you've made your own professional decision, but we just need to stress that at the moment we're just waiting for catch up, and the licensing hasn't caught up as well. And I've been talking to the farmer, and there's a class license going through, as hopefully that is clear to everyone. And the presentation is definitely going out in the video, and we've got a very efficient person on it now, so it will be out very shortly, which I'm so happy to say.
And yeah, we will send the slides out, Abby. Everybody will get a copy of them. Like I said, I was a bit lazy, and a lot of them are copied and pasted from GINA, but the references or the links are at the end anyway that you can link onto. Like I said, it was kind of a whistle-stop tour today and a bit of a general update, so I'm really sorry if it wasn't as useful or as in-depth as some people wanted, but I hope everybody's taken away something. And for anybody that's a bit newer to asthma, or if you've got any colleagues new to asthma, we are doing an introduction to asthma diagnosis and management in February, which will be a lot more in-depth and covering all those basics. So even if you've been doing it for a while and you feel you need a bit more of an update, you're more than welcome to attend that. It is unfortunately with myself again, but I can definitely do the basics. It's the more complex stuff that I still feel nervous with. So and feel free to come along to that or share it with colleagues as well. Daniel said so it's on the Training Hub's website. So if you go onto the Training Hub, there is links for lots of upcoming topics. So I'm doing one on asthma, one on COPD, and one on type 2 diabetes. So we'll be covering from the start. So how do we identify the symptoms? How do we decide what it's likely to do? What tests do we need to do? How do we treat, i.e. following those pathways and looking at useful resources to just build that confidence with you undertaking those reviews and supporting patients. And like I said, I'm quite honest, so there's certain things that I still don't know. So if you lot ever ask me a question or things I don't know, I will tell you I don't know, and I will make sure that we find out from the correct people, and we can get back to you. So, but yeah, please take a look at those sessions coming up. I see Lawrence just put it in the chat. So,
and if you haven't got the app, and you would find that useful, then there's also the Training Hub app that you can download, and you can put your preferences. So if you only want respiratory updates, then you can set your preference to that.
Yeah, thanks so much everybody for joining us. There's no more questions, we'll end it shortly, but I think everybody's got our emails, or obviously you can get in contact with us through the Training Hub if you need to. Thanks everybody for your time.